So I want to welcome you to the 8th International Symposium on Malignant Pleural Mesothelioma. And on behalf of the sponsors, of which are the David Geffen School of Medicine and the Pacific Heart, Lung, and Blood Institute, specifically the Pacific Meso Center, who are co-sponsoring this. We're all eager to hear the incredibly good talks that we're going to have today. They're very interesting and are very, what people call cutting edge on potential therapies and other things related to mesothelioma. So we're at the Meyer Renee Luskin Center, which is, I think, one of the best things about UCLA, because this facilitates these kinds of interactions and goes a long way to help us do these kinds of symposia. So I'm just going to launch into my talk, which is the first talk. I changed the title slightly, so some of the things may not match everything in your packet. But what I want to really talk about is ImmunoSurgery, and that was going to be my title initially. But I'm going to talk more about part one, which is the postoperative immunologic environment in the chest after doing surgery. Because if we don't know anything about that, we can't really modify it in any way that might be useful. So we're going to look at that a number of different ways. So my disclosures are that I'm a scientific advisor for PHLBI. So some of the things I'm going to go over are definitions, a little bit of history, because I'm a history major from college, so I always like that. I'm going to review some data that's available already about some kind of really almost ancient immunotherapies, some new data that we have, and then possible future applications. So ImmunoSurgery is what I'm defining as an immunologically rational combination of surgery and perioperative immunology or immunotherapy. And the goal is to modify the local tumor environment as well as the host's immunologic response to surgery so that there's enhances tumor cytotoxicity and control of the tumor. And generally, this would include intraoperative therapies, because we have an opportunity to do that, but also could be combined with pre- and postoperative therapies. And even other more traditional therapies, including chemotherapy and radiation and targeted therapies, et cetera. But most importantly, this is not kind of what's been going on recently in a lot of trials, which is, hey, we have a new drug like atezolizumab, let's just give it before surgery and see what happens. That's not what I'm talking about. So some of the characteristics of mesothelioma are important, and the reason why this might work uniquely with surgery. And so mesothelioma is diffuse. However, doing surgery never removes all the tumor cells, like everybody in the room I know knows. So an R0 resection is not possible. So at the time of surgery, you're leaving tumor cells in the chest, but it also gives an opportunity to do something at the same time. Standard therapies are not very helpful, and they've been looked at with relatively minimal effects. And also, one of the things that some surgeons don't really appreciate is that the surgery itself can spread the tumor into new areas. So if you do more radical surgeries, it can actually be worse for the patient. But both the pleurectomy decortication and EPP, or extrapleural pneumonectomies, give you an opportunity to do something to the surgical bed, which and some people say that we're only a millimeter or two from a cure. So if you can do something intraoperatively when everything's exposed, then that potentially is a very beneficial way to approach things. So now I want to review a little bit about history. This is lung cancer, but this is a trial that was done published in 1976 by Martin McNeely, who I actually worked with at the University of Toronto when I was there training. And the idea was that they kind of noticed in some lung cancer patients who had infections after surgery that they actually did better than patients who didn't. So they looked at a total of 39 patients who were undergoing surgery for early stage lung cancer. And so they staged them all as pathologic stage 1, which today is actually some 1 and some 2, because it's been changed. And then what they did is they gave them BCG. So into the chest tube, or if they had a pneumonectomy, into a catheter, they actually injected BCG into their chest, and because of the immunologic reaction, they had to give them aspirin and Benadryl in order to kind of blunt the response. And then after 2 weeks, they started treating them for a potential infection with INH. So the inflammatory process that was going on, because of this, they were interested to see what happened to the patients. And so when they looked at the follow-up over 4 years, they found that there were 9 recurrences, and of those 9 recurrences, there were 5 deaths, and they all occurred in the control group. So the BCG group didn't have any recurrences. So that was kind of intriguing, and some of the kind of early information regarding immunosurgery that potentially combining the different aspects of the immune system and surgery works. So now what I'm going to do is talk about some available data. Some of this is old data. Most of it's old data, to be honest with you, but I think it's important to understand this. And there's 2 different aspects of the data. One is there's tumor therapy trials and also some effusion trials and characteristics. So I'm going to talk about those a little bit separately. So just for historical comparisons, when we look at all this data, you want to look at what other people have been able to, really accomplish with other treatments. So the only standard FDA treatment for mesothelioma is chemotherapy with pemetrexed and cisplatin. And this is a trial that was published in 2003 that showed that with chemotherapy, the median survival, I guess I can use this thing, huh? Here was 12 months. And that was better than almost 3 months better than the control group, which is really a big difference in oncology. So this was really impressive. But I want you to keep in mind the 12 months. So that's kind of what this best chemotherapy could do for median survival. Since then, there's been other trials, and one of them has been the MAPS trial, MAPS-1 trial, which showed that adding bevacizumab to this 2-drug combination actually did better. And now they had, if you see here, the median survival is up to 18.8 months. However, one of the interesting things is that the 12 months here is supposed to be comparable to 16 months here. So I think they were treating earlier stage patients, and that's why one of the reasons why their median survival was so high. And if you look at the surgical literature, there's the Sugar-Baker data from, I think, 1999 that was published and showed that even with surgery, radical surgery, radiation, and chemotherapy after surgery, the chemotherapy most of the time was ineffective because this was before pemetrexed and cisplatin, the median survival is only 19 months. So in general, we have a hard time overall doing better than somewhere around 18 to 19 months in terms of patient survival. So I just want to keep that in mind. So what I'm going to do now is look at a few trials that were published looking at using some old immunologic agents. One is IL-2, and this was a trial of IL-2 put intra-pleurally, so the patients just had catheters placed. They had mesothelioma, 22 patients. Most of them were epithelioid, just like we normally see. Most of them were also stage 2, so they were kind of not early stage, but not late stage. And they were given 21 million units of IL-2 into a catheter, into the pleural space for 5 days. Now, 5 days is not a long time to rely on an immunotherapy to work, so this is a really short treatment, yet they still had 11 partial responses and 1 complete response, which is actually pretty amazing. And this is the survival of these patients. I don't know if that's better. You can see it better than I can. But the median survival, interestingly, was 18 months. So it's just about the same as doing radical surgery, chemotherapy, and radiation. So it kind of makes you wonder about how useful some of the radical treatments that we're using. And interestingly, over here you can see 2 groups. One is called the responders, the people who actually respond, and then versus the non-responders. Now, I don't usually like this comparison because it's not really fair, because responders always do better. But if you look at the more favorable group, they had a 28-month median survival, and that kind of rivals any kind of thing that we can do even today. So even though this is an old trial, it's interesting that the survivals aren't much different than what we're doing currently. So another trial that was done, and this is a little bit different. This is an alpha interferon trial. So it's another immunologic agent. It's available. We actually use it on our patients quite a bit for maintenance therapy. So it's an interesting trial. It's a phase 2 trial of intra-pleural interferon alpha, but it's for control of pleural effusion. So it wasn't specifically for treatment of the tumor, but it's control of pleural effusion. So there were other tumors, lung, breast, and some other ones that were in the group, but there were a couple of mesothelioma patients. And I think it's somewhat interesting to see the results. They were given 50 to 75 million units of interferon alpha through a chest tube, again, a pleural catheter for up to 3 installations, and usually about a week apart if they need them for control of the effusion. And for this data, there was some toxicity, which was mostly a flu-like syndrome, which is true of these types of agents. If you look at the results, now this is complete response, partial response. The response, though, is control of the effusion. It's not getting rid of the tumor, so it's a little different endpoint. But you see here in the mesothelioma, there's only 2 patients, but both of them had a complete response. So it does indicate that they seem to respond a little bit more to immunotherapy than even other things that we do, like tau pleurodesis. This is, again, another interesting treatment trial. This is a trial of interferon gamma. It's something that was done a long time ago in France. They had a lot of patients, 89 patients. They put a lot of patients on clinical trials in France. They do a good job. They were the ones that did the MAPS-1 trial too. These were all supposedly early stage tumors, although the staging is difficult. They were given 40 million units weekly for up to 8 weeks. Again, 8 weeks is not a long period of treatment, and even if you were to give modern immunotherapy to somebody for 8 weeks, you wouldn't expect really almost any responses by that period of time. But they did a CT 2 weeks after the end of that 8-week period, so 10 weeks after they started the treatment, and that's how they assess patients. Again, primary toxicity was fevers, but they also had a problem because this was going over 8 weeks of having some catheter-related infection, so that was one of the issues that they had. Now this shows the responses by the stage. So the stage is listed over here, and there's complete and partial responses, but I just kind of highlighted the only real number that I want you to look at, which is a 19% response rate. And that's actually fairly close to many of the immunotherapy results if you look at single-agent immunotherapy with modern drugs. Interestingly, if you look at stage down here, stage 1 versus 2 disease, the stage 1 disease had a response rate of almost 45%. So if you had earlier disease, it seemed like people would respond much better. And here's the stage 1 versus stage 2 data. So it shows that 28 months survival in patients with stage 1 data because they did very well. Now, one of the issues with kind of the staging and all this is that the staging system is really hard, and mesothelioma doesn't lend itself to being staged very easily. So it's hard to know how they decided what stage 1 and stage 2 really were. But in coming up in some of our talks, we're going to have some volumetric MRI data and that kind of thing, which is really going to be helpful, I think, in really determining better staging for these patients. As part of this trial, in a separate publication, they actually started to look at some of the things that are going on in the pleural space. So they looked at levels of IL-6 and looked at circulating CD8 levels, which are CD8 positive cells, which are the cytotoxic T cells. And you saw this, the IL-6 levels actually went down. I'm not sure exactly what to make of that, but they went down, and then as an isolated observation, that's really all it is, and the circulating CD8 positive cells went up. So it seems like there was an immunologic response. Finally, there's a trial looking at all 3 of these, well, actually not 3, interferon alpha and beta and IL-2. So it was just all done in a single trial. Again, 70 patients with a relatively large number. There were doses that were reasonable, but a little bit even on the low side because it was done as an outpatient. And then the toxicity, again, was just limited to fever on the day of the treatment. And if you look here at this one line that's highlighted, you can see that mesothelioma, as compared for IL-2, as compared to the interferon groups, had a much higher response rate, 80% response rate from the IL-2 group versus a very low response rate from the interferon group. So it's kind of something that hints at that maybe IL-2 would be the best molecule to try in terms of these particular cytokines. So from this information, I would say that these trials have shown that there's arguably a reasonable response rate to these kind of agents, even though they're old agents and are not really used a lot in most tumors these days. But they kind of rival most of our modern results as well. The treatments, as I said, are really short and kind of empiric at best. So if they were really done a little more logically, they might have a lot better results. The therapy, like I said, was short-lived, and it wasn't done in some instances for even tumor responses. And all the kind of modern concepts of delayed immune responses and pseudoprogression weren't even known at that point. So some of the questions that at least I have at this point is like, what are the actual cytokine milieu characteristics in pleural malignancies? Are there deficient cytokines, ones that aren't there that should be, that would be better to have there? We can actually add, like IL-2 potentially. What happens after surgery? In terms of the environment, that may be different than with an intact pleura. And also, how, if you're going to give perioperative therapies, how should they be monitored? There's some data that suggests that if you have so one of the other studies that was done looking at just effusion characteristics. So this is looking at general malignancy versus infection. This is an interesting study. It looked at lung cancer patients, 202 advanced lung cancer patients, and they compared them to TB patients. So this is between 1995 and 1998. This is from actually from China. They looked at only 3 cytokines. So they decided to look at GM-CSF, IL-10, and interferon gamma. Interferon gamma, I understand, IL-10 and GM-CSF are relatively random cytokines. And what they found is that there were cytokines present in most of these groups. They were kind of moderate levels. These are all picograms per ml, which is a standard kind of measurement. But one of the interesting things in the TB group, there was a lot of interferon gamma. And as you recall, TB has the same response that BCG does. So some of the early data with lung cancer could have been inducing interferon gamma as a treatment in terms of the BCG original trial that I mentioned. But TB was a very good inducer of interferon gamma. But just having a malignant pleural effusion was not. It was actually very, very low. And the other ones weren't really significant. So another trial looking at 44 patients with malignant pleural effusions, particularly mesothelioma, breast cancer, and lung cancer. These were not patients who were surgical candidates, so they weren't going to have any major procedures, but they had their effusions looked for 14 cytokines. And this, again, is a number of cytokines you can measure depends on the sensitivity. So they found that 9 of the cytokines they tried to measure were too low to even measure. So it ends up only showing 5 levels of 5 cytokines. And so here's these results. If you look at the different colors, these are 5 bands. The darker bands are the ones that really have significant differences, and they show that even up to almost 2,000 picograms per ml are present, particularly in mesothelioma patients. The mesothelioma patients had higher levels than other cancer patients, non-small cell lung cancer and breast cancer. Now, the problem with all this is that it's not controlled for the amount of tumor, so some patients may have had more tumor in there and may have had more cytokines because of that, but in general, the meso patients had higher levels. So one of the next questions is, what about the cytokine levels after surgery or even with surgery? And so Joe Friedberg was doing some surgery with PDT, photodynamic therapy, and he decided to look at 9 patients of his. And they were looking at 8 of them underwent pleurectomy and 1 an EPP, and they were doing photodynamic therapy at the time. They decided to look at 4 cytokines: IL-1 beta, IL-6, IL-8, and IL-10. And these are a lot of them are acute reactants, so these occur when you injure tissue, so they were appropriate for what he was looking for. So what they did is they looked at baseline before they actually really start the surgery, and then they looked at during the surgery up to post-op day number 1, which is a very short period of time. It's basically 24 hours. So it doesn't tell us much about what happens after that. And what he found is that there's 4. These are the 4 changes in the cytokines. These changes were not significant, but he found that up here IL-1 beta and IL-6 changed significantly from baseline, but that's about all you could say. And he concluded that this was just partly from the PDT that he was doing as well as surgery. So that's kind of meager data to go on in terms of how do we apply immunotherapy, particularly during surgery and afterwards. So I want to look at some other information now that we have generated, which is what are the pleural cytokine levels after pleurectomy for a longer period of time. So we looked at a cohort of 21 patients who were undergoing surgery for mesothelioma. All of them had pleurectomies. And we took post-operative chest tube drainage daily and banked it, and then we assessed the immunologic significance of different cytokine, chemokine levels, and we compared it. We wanted to do is compare it to a group of patients that did not have a big surgery. So we found some other patients as well. So we looked at 42 different cytokines. So it's a few more than people have looked at before. And there's a whole bunch of acute inflammatory cytokines like this group. These react mostly to the acute injury, but they include other things like TNF-alpha, which has been a tumor treatment method in the past, at least in animal models. And there's also other ones we looked at, which include a lot of cytokines that have to do with the immune response to cancer and tumor, including the alpha interferon, gamma interferon. We also looked at monocyte stimulatory factors like MCP1 and 3 and MIP1 alpha, MIP1 beta, and also the ones that we just talked about, IL-2, also IL-12, both the heterodimer and homodimer form, as well as IL-15 and IL-10. So a lot of things to look at, and we looked at it these are the ones that we were particularly interested in. So this just shows you kind of what the responses are. This is IL-1 receptor antagonist levels, and these are the 21 patients. You can see that generally they hang out down here and they start to elevate, but there's some people that elevate very quickly. If you look at the controls for this, once you get the mean and the standard deviations, this is what it turns out to look like. And then what we did is we plotted all 42 cytokine chemokines here, and this is what you found, which is the levels here are way higher than people have had in the past. So we have up to 28,000 picograms per ml in these cytokines. So you see that again. This is over time. Down here, I didn't choose every day, but we did days 2, 4, 6, 8, 10, and 12, up to 14 days. And we did every other day measurements, and we looked at the trends. There are some things that we could tell. There are some cytokines that started low and then peaked, particularly around day 10 or 12. And then there were some that started a little bit high and decreased, and some that increased slowly over time. There were some that really had, like GRO alpha is a very acute phase reaction to trauma, as well as GCSF and IL-8. So those are all appropriately elevated, very high. So then what we did is, the rest of these are all the way down here. So it looks like there's nothing else is very significant, but what we did is then eliminated all these high ones, and then this was what was left, and then we just basically slid the scale up, and then we found that a little farther down, this is still up to 5,000 picograms per ml. Lots of different cytokines that are elevated. Again, most of these are reacting to the acute inflammation and are not necessarily associated with cellular cytotoxicity. So again, IL-6, IP-10, these are all things that are acutely reactant. But one of the things that I thought was the most telling is that if you do this several times, so you eliminate all those, you slide it up again, you get some more, and then you start to get to a few things like TNF-alpha down here. But now we're down to a level of about 500 to 1,000 picograms. We have basic FGF, which is something that we've been interested in the past. And then you eliminate those and you slide it up again. Now we're down to only 100 picograms per ml. And now you start to see things that are important, like IL-12, which has to do with cellular immunity, interferon gamma, interferon alpha are both here. And then if you do it one more time, you get down to less than 10 picograms per ml. You start to see things like IL-12 heterodimer form and IL-2, TNF-beta. So things that are more associated with cellular immunity. So we found is basically that in the chest after surgery, at least as measured by chest tube drainage, most of the cytokines that are there are inflammatory cytokines and tend to have, if anything, an immunosuppressive effect on the cellular immune system. And the levels of important cytokines like IL-2 and IL-12 are very low, if almost non-existent. So what we did then is kind of set up a grid and we characterized these. So we had this table which shows ultra high, high, medium, low, and ultra low levels of cytokines. So we divide them all up in here. You can see they're generally, for mesothelioma, divided among all the different levels relatively equally. And you can see most of them are increasing or stable. There's only a few that are actually decreased. And so that makes sense from the standpoint of the injury. Now, one of the questions is what happens if you just put a chest tube in somebody and don't do a lot of surgery? Is this the same thing? And so what we did is tried to find other groups of patients that we would normally put chest tubes in and collect chest tube drainage from them. And so one of the groups was actually esophageal cancer group. So we did esophagectomies, and in the part of that's done mostly not in the pleural space. That's done in the mediastinum. And occasionally patients need chest tubes placed just because they have a opening into their mediastinum, from the mediastinum into the pleural space, so they need just to drain the fluid. So the fluid is much less inflammatory than like a pleurectomy patient. So we did the same thing for these patients and looked at their cytokines and did the same kind of thing. So basically, the different cytokines are very similar. As IL-1 receptor antagonist, GRO alpha, all these were all the same ones that were high before. However, this is the highest level of these, and this is only less than 5,000. So the level was way less than the previous in mesothelioma in pleurectomy patients. So we slide it down. Again, basically seeing the same groups in similar areas, but until you get to this, which is again less than 100, and you have the interferon alpha and IL-4 and interferon gamma, and the IL-2 ends up being way down here. So again, you saw the same kind of pattern, but the level of elevation was much less. So the ultra high, there was no cytokines that were in that level. They ended up being more closely spaced down in the lower levels. And when you look at the different changes in the cytokines over the period of that recovery, there's almost none of them that increase. And these only were increasing because their levels were so low that they just go up a little bit, and they met the criteria of doubling over the period. Most of them are either stable or decreasing. So it's a different pattern of chemokine, cytokine production. So I think this is some really helpful information because it tells us what's normally happening in after surgery, which is almost everything that's happening is not amenable to the immune system, at least the cellular immune system. So it opens the door to potentially modify at the end of the surgery what we're doing in order to get a better outcome. So some of these open questions that I brought up earlier is what is the cytokine characteristics in patients with pleural malignancies, particularly mesothelioma. We talked about that. So that we kind of know there are deficient cytokines in terms of there are low levels of cytokines that we would like to have high levels on. So that was definitely documented. And the effects of how should the effects of perioperative therapies be monitored? We saw data that suggests that we need to be monitoring the pleural space and not just the serum, which is what a lot of people do. So what are the optimal approaches to use this information to treat patients? That's the next question. And so there are some possible future approaches. I think one of the things, I'm not going to talk about this one. One of the things that I talk about is a trial that was done and published and is going to be added to using add interferon. So interferon alpha we saw had low levels. We saw before that there is data that suggests that if you treat with interferon alpha that you can get therapeutic responses, not only to pleural effusions but also potentially to cancer levels if you treat intrapleurally. So this was a trial giving adenovirus with an interferon alpha gene into the pleural space through a pleural catheter. And it was given twice, days 1 and 4, and then they were followed. And they had actually quite severe symptoms. They had very severe flu-like symptoms, and actually the initial dose had to be lowered because the initial cohort had too severe symptoms of the flu, and they actually all of them didn't want to have a second dose, so they only got 1 dose. So they lowered the dose and then looked at the responses after a little while. So there's 2 responses, but what you saw was kind of a strange combination of different things. So these are PETs and CT scans. Well, actually all PETs. And if you look here, it's pre-treatment, then there's 2 months and 6 months. So again, this is a short period of time for immunotherapy, and there's several different arrows here. So over here, there's an arrow that's kind of pointing to the hilum of the right lung, and looks like there's lymph nodes that are lighting up there. And that one actually gets better by 2 months and stays better after that. There's a lymph node down here that's right next to the trachea, which wasn't really present pre-treatment, but then got bigger and quite big on this one. You can see it very plainly there. So that looked like the tumor was progressing. However, there was this bigger other area now this is in the pleural space, and this one didn't really do much by 2 months. But by 6 months, it actually disappeared. So there's a mixed response to the tumor, and the conclusion is kind of that the intrapleural stuff, the stuff that's was exposed to the adenoviral vector and interferon, actually probably responded in some instances, whereas the extrapleural stuff, that's the lymph nodes in the lung and in the hilum, didn't respond. So this is being now expanded as a phase 3 trial, which is one of the trials that we'll be participating at UCLA. So I think it's interesting. 2 patients also end up undergoing surgery, but that wasn't really part of the report. So what are the possible ways that we can use these kind of treatments in the future? So if somebody comes in and has a newly diagnosed mesothelioma, what we can potentially do is something initially that I haven't really talked about, but as part of the immune system, you want to prime the immune system to recognize antigens. So one way that we've been starting to explore to do this is to use one of the things that Dr. Apton helped develop at UCLA, which is cryoablation. We do that for small nodules, particularly post-op in patients who have recurrences, and it controls them very well, but it creates also a lot of antigen in the localized area. So if you add a vaccine adjuvant and potentially prime somebody with a short course of IL-2, you might stimulate the immune system to be ready for some manipulation. And then what we can do is go ahead and do our pleurectomies. And during the surgery, we can do intraoperative therapies that might take advantage of the fact that the patient has a primed immune system to mesothelioma antigens. There are other things that we've also worked on, which are some of these things: betadine therapy, cryotherapy, IL-4 immunotoxin. Those are related things that you can do intraoperatively, but really the other thing you can do is intrapleural manipulations, IL-2, you can do interferon, other cytokines or chemokines that will modify the environment after surgery. And then after you've done that, and you've kind of started the process, then you can, after surgery, you can add in things like PD-L1 inhibitors or blockades so that you can keep the activated system going, or add other things like additional vaccines and interferon, or the standard therapies as well. So this can be kind of a complex cycle, but this makes more immunologic sense than what other people are doing, is just adding a PD-L1 blocker to preoperative therapy or postoperative therapy. That's not likely to have a big effect. So, kind of in conclusion, intraoperative therapies I think are promising because they have the entire tumor bed available, and all the tumor cells in many patients are just within a millimeter or 2 of your treatment area, so you can treat it in a very broad way with low systemic toxicity. The traditional intraoperative adjuvant chemotherapy, for instance, that some people have worked on, is not ready for prime time and probably shouldn't be done because the agents just aren't specific enough. Our knowledge of immunology and immunotherapy is growing rapidly with the successes that we've had, so that's helpful. But I think even some of these older treatments like interferon, IL-2, the treatment, the way that it was done in the past was probably not optimal, and there may be still benefits from these kinds of molecules when they're combined with some of the newer blocking molecules. So we should probably rethink, reconsider what we're doing, and even maybe recycle some of those therapies with newer knowledge and approaches that can get better results, hopefully. So as most people know who do research, it takes a lot of collaborators. It takes a village. So I just want to thank all the people that I work with. Olga Oleski's going to talk next. She's our medical oncologist. Dr. Apton, who's one of our interventional radiologists who we work with on a weekly basis with all the patients, and Lin Huafeng, who's our key nurse practitioner, mesothelioma nurse practitioner. But also on the research side, Masa and Yuki Tone, who are here today, and Masa is going to give a talk. There are mesothelioma scientists that are spending their entire time working on mesothelioma and the newer treatments in immunology. Claire, who's the director, who does everything we need to do in order to kind of get all the results. Also down here, these are not the last and least, but these are important, is the OR nurses and the 7 West floor nurses who take care of all our patients and make sure that they generally do outstanding after these big surgeries. I want to specifically thank Grace Lee, who's one of our undergraduate UCLA students who helped generate all that data that I showed. So if it wasn't for her, I wouldn't have a presentation today. So thank you.